Thank you so much for joining us for another session of Radiology Ground Rounds with our Health for the World team. Today, it is my pleasure to introduce our speaker, Dr. Ellen L. Wolfe, who will be giving a talk entitled Radiologic Evaluation of Small Bowel Obstruction. Dr. Wolfe is a professor of radiology at Montefiore Medical Center and the Albert Einstein College of Medicine in the Bronx, New York. She completed her residency training and fellowship at Columbia Presbyterian Medical Center with also a stint at Johns Hopkins. And her clinical and research interests center on abdominal and gastrointestinal radiology. Everyone, please feel free to enter any questions you might have in the chat, and we'll also have a Q&A at the last 15 minutes or so of the lecture. And with that, I'll hand the platform over to Dr. Wolfe.
Okay, let me share my screen. Okay, here we go. So learning objectives for today are to describe the imaging findings of small bowel obstruction on various modalities, determine which modalities to utilize in the evaluation of a patient with suspected small bowel obstruction, and to identify problematic areas and pitfalls in the diagnosis of small bowel obstruction. So we're going to start with a little quiz. So which patient has small bowel obstruction? Is it A? Is it B? Or is it C? And we'll see the answers during the talk to this, and then at the end we'll give the answer. So small bowel obstruction is a common condition. However, it's frequently misdiagnosed clinically. It still has a significant morbidity and even mortality, and radiology plays a very important role in its diagnosis. Etiology of small bowel obstruction is adhesions in most cases after surgery. However, there are many, many other causes. If you open up a textbook on small bowel obstruction, you'll see pages of etiologies. Hernia used to be a common cause of small bowel obstruction. However, this is decreasing as a cause because of earlier surgery. People used to walk around with trusses and delay surgery, but now surgery is performed earlier. Various neoplasms, small bowel, large bowel, including particularly right colon cancer that can present as small bowel obstruction. Gallstone ileus, particularly elderly female. So gallstone ileus is the most common cause of small bowel obstruction in the elderly non-operated female. Many other conditions is listed here in addition to others. So the key questions that we should try to answer when we evaluate a patient with suspected small bowel obstruction are: 1, is the bowel obstructed or not? 2, what is the level, cause, and severity if it is obstructed? 3, are there any complications that require prompt surgery? 4, is there closed loop obstruction? And 5, is strangulation present? So we may not be able to answer all these questions depending on the modality that we use. However, this is what we would theoretically strive to do. So how do we diagnose small bowel obstruction? There are many, many ways that we could, as listed here. Generally, we'll start with plain films. We could do barium studies, which would include either a routine small bowel series, enteroclysis, a barium enema with refluxing into the small bowel. Could do CT or CT enteroclysis, ultrasound, MR, or MR enteroclysis. So any of these things could be used to diagnose small bowel obstruction. How do we decide what to do? What are the findings of each? I'm going to concentrate primarily on plain films. We'll talk about some barium studies and concentrate on CT. And we'll have a little bit of ultrasound and MR as well. So plain films are widely available, they're relatively inexpensive, and are widely used for the diagnosis of small bowel obstruction. Generally, we'll get supine or upright views or decubitous view in patients that can't stand up for the upright views. However, it's been shown that the upright view actually increases sensitivity by accuracy by only about 5% in the diagnosis of small bowel obstruction. So we always will get a supine. We'd like to get an upright or decubitous, however, it actually doesn't turn out to be that helpful. Now, we're always looking for these air fluid levels, but we'll talk about that in a minute. So plain films, however, are unreliable, especially in low-grade obstruction. Plain films are only diagnostic of small bowel obstruction in about 50 to 60% of cases. They are equivocal in 20 to 30%, so we can't tell, is this obstruction, is it ileus, is it normal? Normal in about 10 to 20% of cases. So not really great in terms of percentage of diagnosis of small bowel obstruction. In addition, plain films generally cannot identify the cause of small bowel obstruction. Instead, in some cases of hernias and gallstone ileus, we might see characteristic findings on plain film, but usually we can't identify the cause. When we do diagnose small bowel obstruction on plain film, it's inaccurate in determining the level of obstruction. Is it high obstruction, low obstruction? They are inaccurate. So what are the classic findings of small bowel obstruction on plain film? We're looking for dilated loops of small bowel, which would be greater than 2.5 to 3 centimeters in diameter, a paucity of colonic gas. We look for air fluid levels, but as I said, air fluid levels are not specific for small bowel obstruction and can be seen in ileus. What we look for in small bowel obstruction are differential air fluid levels. That is air fluid level in the same loop at different levels. And we might see the more characteristic string of beads or pearl sign, which is fairly specific for small bowel obstruction, and the stretch sign, which I'm going to illustrate examples of this. So the plain film findings in small bowel obstruction, however, are going to be variable. That's going to depend on the level of obstruction. Is it high obstruction? We're not going to have a lot of big dilated loops, or is it low obstruction where we will? The severity, is it a partial, low, or high-grade obstruction, or is it complete obstruction? We're going to see different things. The duration, is it small bowel obstruction that just began, or has it been going on for many hours or days even? And it will also depend on the proportion of gas and fluid within the bowel. So it's very variable what we're going to be seeing. Classic findings are illustrated here in a patient supine and upright. So here we can see clearly dilated loops of small bowel. How do we know these are small bowel and not colon? We can see the valvulae coniventes, which go all the way across the bowel lumen here, which indicate that it's small bowel. Also, it's in the center of the abdomen. The colon is generally going to be in the periphery. We have a little bit of colonic air down here. We would never have this many dilated air-filled loops of large bowel, so this has to be small bowel. So this is the supine view. And on the upright view, we can see this differential air fluid level. So this is the same loop, but the air fluid level is at a different site, different level. So this indicates active peristalsis and is more specific for small bowel obstruction than just air fluid levels at the same level. These other loops show the same thing as well. So this is classic small bowel obstruction. Paucity of colonic gas, there is some, but dilated air-filled loops of small bowel with air fluid levels differential. Now the string of bead sign or string of pearl sign is illustrated here on supine view and decubitus view. On supine view, we see dilated loops of small bowel. Again, we can see these nice valvulae coniventes. This is clearly small bowel, dilated, greater than 2.5 to 3 centimeters. This is a decubitus view. This patient could not stand. We did a decubitus view with the right side up. They're lying down on their left side, the right side is up. So here we see what's called the string of beads or the string of pearl sign, as illustrated here. These little round collections of gas, which is air trapped within the valvulae coniventes. This is a CT, which illustrates why we see this string of beads or string of pearl sign. This patient, of course, is supine, air is rising, and we can see that there are bubbles of gas which are caught between the valvulae coniventes. So there's only a small amount of gas in this patient that has a lot of fluid, and in this case, contrast within the bowel. The air rises, and we see this string of beads or string of pearl sign. We may also see the stretch sign. Now, this is more subtle and not as widely appreciated, but these are parallel Straight lucency is perpendicular to the long axis of the bowel, so we see these black slits. Again, this is the same thing as the string of beads or the string of pearls sign, but actually just seen in a different way. Again, there's fluid-filled bowel, scant gas, and air trapped between the valvulae, but if you look at the CT, if you're looking at an AP projection rather than an axial projection, you'll see these slits. So that's the stretch sign. Now, as I said before, in most plain films, we're not going to be able to diagnose the cause of small bowel obstruction, except rarely in some cases. In this case, there was an inguinal hernia causing small bowel obstruction. Now, you can sometimes have coincident hernias in a patient with small bowel obstruction for another reason, say adhesions. But remember to look at all corners of the film, which we always have to do. This patient had a right inguinal hernia, which was the cause of their small bowel obstruction. Again, we usually can't diagnose the cause on plain films, but in case like this, we at least suspect it's a hernia. So plain films and small bowel obstruction, there are problems with the diagnosis. So if there's a high small bowel obstruction, the obstruction is high in the small bowel, we're not going to see a lot of dilated air or fluid-filled loops of bowel because the obstruction is too high. We're not going to see those classic findings. If the loops are all fluid-filled, if there's been vomiting and the bowel has been devoid of fluid from vomiting, or an NG tube has been placed on suction, we're not going to see necessarily all these dilated loops. It takes generally a day or two for the colon to empty, and even more. So we do not have to have no bowel gas or a paucity of bowel gas, even in some cases, because the colon takes a while to empty. Right colonic obstruction can suggest small bowel obstruction. That could be confusing. Other things can simulate small bowel obstruction. Focal ileus secondary to adjacent inflammation, for instance. Pseudo-obstruction with dilated air-filled loops of bowel, ischemic bowel. This can mimic small bowel obstruction. And plain films are not accurate in the diagnosis of determining the level of obstruction. So it may look like there's a high obstruction when there's actually a low obstruction. And this actually is important because proximal small bowel obstruction is generally more conservative therapy, whereas distal small bowel obstruction, earlier surgery may be considered. So this is a patient that came in with abdominal pain, vomiting, was suspected of having small bowel obstruction. They did this plain film, which was read as normal, which I think most people would agree. We don't see any signs of dilated small bowel, air-filled small bowel. There certainly isn't a paucity of gas and stool in the colon. This was called normal. So can you still have small bowel obstruction? Yes, in this case, they decided, well, maybe they had gallbladder problems. They did a SONA with the right upper quadrant. The gallbladder was fine, but they saw these dilated fluid-filled loops of small bowel and suspected there might be a bowel problem. So a CT was then performed where we could see that there was small bowel obstruction with the transition point between the dilated fluid-filled loops and the decompressed loops secondary to an adhesion causing small bowel obstruction. So why was this plain film interpreted as normal? Why does it look normal? They're all fluid-filled loops. We don't have those air-filled loops that we're going to see on plain film. So the diagnosis could not be made. Another patient that was called normal, then has a gasless abdomen. So a gasless abdomen, again, is nonspecific. Could be small bowel obstruction. And in this case, again, we see multiple fluid-filled dilated loops of small bowel. Can transition to decompressed, non-dilated small bowel, secondary again to an adhesion. Remember, we're always looking for that transition point on CT to look for small bowel obstruction. So this patient with the gasless abdomen had high-grade small bowel obstruction. Another patient, we can see that there are a lot of very dilated small bowel loops. Again, we see these valvulae, but there's air throughout the colon. So we said that typically there's a paucity of bowel gas, but colonic gas, but it takes 2 to 3 days, or 1 to 2 days to 3 days to empty, even more in some cases. So again, this patient had small bowel obstruction. We clearly see a transition point between the dilated and non-dilated bowel, and but they did have a lot of air still in their colon. And another patient, they had these dilated loops of small bowel. It was unclear whether this is obstruction or ileus. This is their upright view and their supine view. It turned out they had a low small bowel obstruction. So in this case, even if you diagnosed small bowel obstruction or considered it, you would think it was probably a high obstruction. However, this was a low small bowel obstruction. The transition point was very distal in the ileum. So we're not accurate in diagnosing the level of obstruction on plain films as well. This patient came in vomiting. They had this big dilated stomach. They were diagnosed as having gastric outlet obstruction. So I would think that's certainly reasonable. However, CT showed small bowel obstruction. So again, another confusing case. This patient came in with lots of dilated loops of small bowel. They were thought to have small bowel obstruction. However, on CT, they had right colon cancer. So if there's an incompetent ileocecal bowel in patients with right colon cancer, fluid can go retrograde into the small bowel, and it can appear small bowel obstruction when there's actually large bowel obstruction, particularly in right-sided tumors. This patient had lots of dilated bowel, many loops of markedly dilated small bowel, paucity of gas in the colon. However, this patient had ischemic bowel. They had an SMA embolus, many loops of necrotic small bowel. So this patient did not have obstruction at all. They had an MSA embolus causing small ischemic bowel. Postoperative ileus is illustrated in this case. This is very common, of course. After surgery, abdominal surgery in particular, many patients will develop a postoperative ileus. And it can be very difficult on radiographic films to determine whether it's ileus or small bowel obstruction. So here in this case, we can see dilated loops, air-filled loops of small bowel. There's some contrast in the colon from a previous CT. Looks like we have the string of beads or the string of pearls sign as well. So small bowel obstruction was considered in this postoperative patient. However, in the early postoperative period, ileus is extremely common, however, and this just turned out to be ileus rather than small bowel obstruction. So in the early postoperative period, people with dilated small bowel will generally attribute to ileus rather than obstruction. So is controversy whether should we even obtain plain films at all, and when small bowel obstruction is suspected, we'll go right to CT. So that's controversial. Plain films can be very helpful. Plain films can be good at diagnosing other conditions, can be very accurate in the diagnosis of bowel perforation, which of course is very important. So it's a little bit controversial whether we should just go right to CT or do plain films. So after plain films, why would you do further studies? If the plain film is non-diagnostic or there's a disparity between the plain film findings and clinical presentation. So I showed you cases where the plain film looked normal, but they ended up having small bowel obstruction. So even with a normal plain film, small bowel obstruction can still be present. And if clinically that seems to be a good diagnosis, you may want to go on to do other studies. You want to do other studies when other conditions that could mimic small bowel obstruction are clinical possibilities. So I showed you some cases that looked like they had small bowel obstruction, but they didn't. Post-op patients with no improvement. So I told you that ileus, of course, is very common in post-op patients, which I'm sure you're all aware of. But if they don't get better over a reasonable amount of time, maybe they actually do have obstruction. And if strangulation is suspected, you want to go on to do CT. So when you do CT or contrast studies that are general, what kind of contrast would you want to use? So say you want to do a small bowel series after the plain film. Do you want to use barium or water-soluble contrast? So people think that inspisation of barium can occur in small bowel obstruction. You give oral barium, but that actually does not occur, but that's not a worry. So this is a quote from Dr. McGlinty. It should be stressed that water-soluble contrast agents have no place in the investigation of small bowel obstruction. So in general, if you're going to be doing a small bowel series to look for small bowel obstruction, you do not want to use water-soluble contrast. Why not? Water-soluble contrast stimulates the outpouring of fluid into the bowel that will dilute the contrast, leading to inadequate mucosal detail and can lead to fluid electrolyte imbalances. With all the contrast getting into the bowel, it can stimulate the outpouring of fluid and lead to fluid electrolyte imbalance. So if we did a small bowel series on a patient with small bowel obstruction, what would we expect to see? We said before, adhesions were the most common cause of small bowel obstruction. So we would see a normal fold pattern, but an abrupt narrowing with sharply demarcated margins or a straight line across the lumen. So this is an example here on a small bowel series. We gave oral barium. We're filling dilated loops of small bowel with a transition to decompressed small bowel in the region of the mid-ileum. And we can see there's an abrupt transition here between the dilated bowel and decompressed bowel secondary to an adhesion. So we can diagnose on this small bowel series, this patient has small bowel obstruction. They're dilated loops of small bowel, decompressed small bowel loops with a transition point due to an adhesion. This is partial small bowel obstruction because we get contrast into the distal bowel after the point of obstruction. So we can make a very specific diagnosis in this case of small bowel obstruction, partial from an adhesion. However, in this patient that had high-grade small bowel obstruction or complete small bowel obstruction, we don't know, we gave barium that became so dilute because of all the fluid within the bowel that we were unable to make any kind of diagnosis. We could say there's dilated small bowel for sure, but we couldn't say where the obstruction was if present or what it was due to. So this was a non-diagnostic study, basically just showing lots of dilated fluid-filled loops of bowel. So disadvantages of the routine small bowel series is that in partial obstruction, the distensibility and fixation of the bowel is not tested. So if there's low-grade obstruction, it may be difficult to make a diagnosis. With high-grade obstruction, like that case I just showed you, there can be delayed filling of the small bowel. It can take many, many hours, even days, to reach the point of obstruction. And we might get dilution and inadequate mucosal detail with lots of fluid-filled dilated loops. Also, giving barium may delay subsequent examinations and interfere with subsequent CT if that needs to be performed. So people have used enteroclysis to get around some of these problems. Enteroclysis is when you put a catheter into the proximal small bowel and put in large amount of contrast with pressure. So this challenges the distensibility of the bowel and can exaggerate minimal or subclinical obstructions and can demonstrate multiple sites as partial small bowel obstruction in some cases. Some people will have multiple adhesions, which are not be diagnosed typically with a routine small bowel series. This was an example of a patient that had a routine small bowel series. We can see lots of big dilated contrast-filled loops of small bowel, and then again transition into decompressed small bowel. Now this patient had had previous surgery, as you can see, for a gynecologic malignancy. They had radiation, they had surgery. What is this obstruction due to? Is this due to recurrent tumor? Is this due to adhesions? Is this due to radiation change? Difficult for us to make a specific diagnosis. This patient went on to have an enteroclysis. We can see that tube here. There's lots of contrast now within the bowel. And we could see that this patient indeed had small bowel obstruction secondary to adhesions with these straight lines going across the bowel. So this was adhesions, not tumor, not radiation change. Now, you could also do a retrograde small bowel enema in patients with suspected distal small bowel obstruction. So instead of putting barium from above, filling all those big dilated loops, which may take many, many hours, finally to get to that point of obstruction, why not do it from below? Fill the colon and reflux into the distal small bowel. So this could be done in patients that have suspected right colon lesions or distal small bowel obstruction. and can diagnose a differential between pseudo-obstruction and distal small bowel obstruction in that way as well. So one example, this patient came in with lots of dilated small bowel loops, looked like a distal obstruction, distal small bowel obstruction. Contrast was put in per rectum and introduced throughout the colon, and we can see that there was a right colon cancer in the region of the cecum, which was causing a small bowel obstruction. So this right colonic lesion was causing obstruction. It was right at the ileocecal valve. Was causing small bowel obstruction, but was diagnosed as right colon cancer, which was much quicker than doing it from above with barium, doing it from below. And this is the spot film of the tumor. However, CT has a lot of advantages in the diagnosis of small bowel obstruction over barium studies and plain films. So CT is readily available. Generally, it's rapid, it's non-invasive, and no technical expertise is necessary except for the technologist training. Therefore, you can make an early definitive diagnosis. You don't have to wait for the barium to get to the point of obstruction. It's been shown that CT reduces morbidity and mortality if it's used effectively and it's cost effective. So what are the CT findings in small bowel obstruction? We're looking for dilated small bowel greater than 2.5 centimeters in diameter. And again, that transition point to decompressed bowel. We're always looking for that transition point. So CT can generally identify the etiology of obstruction, can sometimes at least determine whether it's complete, partial, and the grade of obstruction by seeing if contrast gets beyond that point of obstruction into the decompressed bowel, it's only partial. If the small bowel is markedly dilated proximal to that point, it's more high grade than low grade. We always want to determine if we see small bowel obstruction, whether it's closed loop obstruction, because there's a higher incidence of complications with ischemia with closed loop obstruction. On CT, we're always looking for evidence of volvulus ischemia and perforation as well. So should we give oral contrast when we do CT in patients with suspected small bowel obstruction? So people who say no say that there is not necessary because there's natural contrast of fluid and air already within the bowel. I've showed you some CTs where we can see that there was all this fluid. We didn't need to give oral contrast because there was already fluid and air in the bowel, which is a natural contrast. If you're giving these patients who are already vomiting a lot of contrast to drink, there's a risk of aspiration. If you give oral contrast, it can obscure abnormal bowel wall enhancement patterns or normal bowel wall enhancement patterns as well. If you give oral contrast, it may not even reach the point of obstruction unless you wait for a long time. And there's a delay in obtaining the scan. If you give oral contrast, they need to drink the contrast. It takes a while for them to do that. Obviously, the scan is going to be delayed. However, people say, yes, oral contrast is helpful because we could differentiate partial from complete. If we see contrast getting into the distal small decompressed bowel, it's only partial. It's more helpful to determine the level of obstruction and the cause of obstruction if we give oral contrast. So this is controversial. Some people always give it, some people never give it, some people sometimes give it. So there's no really right or wrong answer. So again, on CT, this is the classic finding of small bowel obstruction, dilated fluid-filled bowel, decompressed distal small bowel, and there was an adhesion with a abrupt transition, no mass, no other findings at the level of obstruction. This was from an adhesion. Another patient was diagnosed with metastatic cancer. This is a large mass, which was causing small bowel obstruction. There were multiple masses in the bowel. There was ascites. This patient had a metastatic tumor, which was cause of their obstruction. So there are abnormalities with characteristic CT appearances that cause small bowel obstruction, which are generally very easy to diagnose. Hernias are easy to see on CT, intussusception as well. Malrotation can be a cause of obstruction with Ladd's bends or volvulus. Gallstone ileus, which we mentioned was a common cause of small bowel obstruction in the elderly non-operated female. and closed loop obstruction. We're always want to determine whether obstruction is present if it's closed loop. So an example here of a patient that came in vomiting, they were suspected of having small bowel obstruction. We can clearly see there's dilated, contrast-filled bowel in this case, and we can see the cause clearly as this ventral hernia as the cause of small bowel obstruction. So we were able to get a very rapid diagnosis, and this patient went right to the OR and was treated very promptly. Spigelian hernias can be difficult to diagnose clinically. These are hernias that occur through the linea semilunaris, where there's a weakness in the internal oblique and the transversalis abdominis muscle, transversus abdominis muscle. So there's herniation of bowel beneath an intact external oblique muscle. And again, these are often not diagnosed on physical examination. They can be difficult. So an example here of a patient with Spigelian hernia, we can see his bowel in the anterior abdominal wall extending out from the abdominal cavity. This was a Spigelian hernia, which was causing small bowel obstruction. Again, a very easy, quick diagnosis. This patient went right to surgery. Obturator hernias are another hernia that's difficult to diagnose clinically. These tend to occur in elderly, multiparous thin women. They're more common on the right side, supposedly, but I've seen some on the left as well. Plain film, you may see air of the obturator foramen. This, of course, is not reliable and not seen in most cases. On CT, we can see bowel between the pectineus and external obturator muscles. Clinically, you might see the Hauscha-Romberg sign, which is pain passing down the inner thigh, because the obturator hernia presses on nerves in that location in some cases. So this is an obturator hernia. So we can see here that there's bowel, which doesn't belong between these two muscles. This was obviously on the left side. This is supposed to be more common on the right side. But so remember, we have to look at all the corners of all the films, and this was on the lowest scan, lowest image, obturator hernia. And then intussusception. Intussusception has this very characteristic appearance on CT, where we can see that there's fat being dragged into the bowel by this intussusception, which is the cause of small bowel obstruction, easily diagnosed. Now, one of the signs of small bowel obstruction on CT is called the small bowel feces sign. Small bowel feces sign is gas bubbles with particulate matter and dilated small bowel due to undigested food from delayed transit within the obstructed small bowel typically. It can occur, however, in patients with stasis. Doesn't always indicate obstruction, but most patients will have small bowel obstruction. This is a case of illustrating the small bowel feces sign, where we can see this bubbly particulate matter within this dilated loop of small bowel. Again, we see transition to decompressed small bowel. At this point, there was an adhesion. And this small bowel feces sign tends to occur right at the point of transition between the dilated and non-dilated bowel, so that this is a marker for small bowel obstruction. And if you see this small bowel feces sign, you should look right distal to that to see what the point of obstruction is at that point. So that's the small bowel feces sign. Occasionally, the small bowel feces sign can be seen on a plain film. This was actually the scout image for the CT, but we can see that there is this bubbly pattern, which could be confused, of course, as fecal material in the colon. However, on CT, this was actually within the small bowel. This was a small bowel feces sign, which occasionally you can see on the plain film. Here we can see these dilated loops of small bowel feces sign. This is small bowel obstruction. Now, closed loop obstruction, I mentioned several times. It's very important when you see what looks like small bowel obstruction to determine if it could be some closed loop obstruction. Closed loop obstruction is defined as one loop of bowel which is occluded at 2 points. So the etiology of closed loop obstruction is typically adhesive bands or internal hernias. And as we said before, it's important to diagnose closed loop obstruction because there's a higher incidence of bowel ischemia in this circumstance. So this illustrates what we mean by closed loop obstruction. And in this case, there's a hernia where this loop is obstructed at 2 points as it goes in and out of the opening. This is the patient that has adhesions. So this loop of bowel was caught between this adhesion, single loop, which is being obstructed at 2 points. And if this volvulates, it can lead to ischemic bowel. So are there any plain film findings of closed loop obstruction? Very rare to be able to diagnose closed loop obstruction on plain films. You may see a pseudotumor of fluid-filled loops of bowel, a coffee bean sign of opposed bowel wall loops, fixed loops on serial films if you're taking those, but it's rarely diagnosed on plain films. So we can't rely on plain films to make that diagnosis. This is the patient that came in with vomiting, thought to have small bowel obstruction. Indeed, we see these dilated loops of small bowel, paucity of gas in the colon, but there was this big soft tissue density within the right lower abdomen and pelvis. Was this a mass? What was going on here? There's a lot of soft tissue density in this location. CT was performed, and we can see this is actually closed loop obstruction. These are many, many loops which were involved in this closed loop, which there was an adhesion. All this bowel has herniated through that adhesion and has led to this radial distribution typical of a closed loop obstruction. When you see closed loop obstruction, you also have to look for signs of ischemia, which we're going to talk about again later. So here we can see this patient had, if you have closed loop obstruction, this loop may twist and produce a volvulus. And ischemia may result if the blood flow is compromised, which is called a strangulated obstruction. So ischemia and strangulation are the main reasons for morbidity and mortality in patients with small bowel obstruction and closed loop. So the CT findings in closed loop obstruction are going to depend on the orientation of the bowel and how many bowel loops are involved. So here we see this one single loop, an adhesion, and then it twisted and caused obstruction, closed loop. If it's located, oriented in this vertical position, you're going to see something different when you do CT than if it's located horizontally in this location. And if there are many, many loops, as illustrated in this case, you're going to see something different. So in that other case I showed you, where they had this soft tissue mass on CT, they had many loops and they ended up having this type of appearance with that radial distribution. So CT findings in closed loop obstruction, what are we looking for? We're looking for 2 collapsed adjacent loops, a fluid-filled distended loop in a U or a C-shaped or radial distribution, stretched and thickened vessels converging to the point of obstruction, and or the whirl sign due to twisted mesentery. And we'll see examples of what I mean. So this patient, if you did an axial scan through this many, many loops of volvulated bowel, we would see this radial distribution. This is very characteristic of closed loop obstruction. In this patient, we can see that there's a C-shaped, isolated, dilated loop due to this bowel which is obstructed in 2 points. This is isolated. All these other loops, these are a little bit dilated, but this is out of proportion and has a C-shaped configuration. There's also a lot of mesenteric edema, bit of mesenteric edema, which points to possible ischemia. So this is another configuration of closed loop obstruction, the C-shaped loop. This patient looked like they had small bowel obstruction based on this beak. This is a beak sign of small bowel obstruction, dilated loops, transition to decompressed loops at the level of the beak. However, when we did this coronal plane, we can see this was actually a loop of closed loop obstruction. There was an adhesion right here. We don't actually see the adhesion itself, but we see the result of it. With this loop, it's a closed loop obstruction with this, it's another C-shaped loop in this projection, but on the axial, it was hard to diagnose. So having additional planes, coronal, sagittal, can be helpful. Sometimes even need to do oblique root formats. Note the small bowel feces sign as well here. So this is a patient that came in with small bowel obstruction. Again, we see the dilated fluid-filled loops, transition to decompressed loops. it wasn't anything really specific for closed loop, but it kind of looked like sort of funny tethered loops, possibly in this location on the axial plane. It just looked a little strange. We did reformats in the coronal oblique position, and we can clearly see that this is closed loop obstruction. These loops of bowel are obstructed at 2 points, and this was clearly closed loop obstruction, which was difficult to diagnose in the axial plane. As you can see, if we're cutting across this way, it's not so obvious. So having these coronal and sagittal reformats can be very helpful. Now, this patient illustrates the whirl sign. So you don't like to see this swirling kind of loop of bowel within the abdomen. This patient here on the coronal reformats clearly again has closed loop obstruction, which was seen by this whirl on the axial. Now, not every patient that has a whirl is going to have closed loop obstruction. Whirls can sometimes be seen in post-op patients, sometimes occasionally for other reasons. But if you see this whirl, you should say to yourself, could this patient have closed loop obstruction if there were any other signs? So strangulated obstruction occurs in about 10% of patients with routine small bowel obstruction, obviously more common in closed loop obstruction. And strangulated obstruction is the main reason for morbidity and mortality in patients with small bowel obstruction. So we always have to be very wary of trying to diagnose strangulated obstruction. So there are many signs that one might see indicating possible strangulated obstruction. Bowel wall thickening is common. These abnormal bowel wall enhancement patterns, as I alluded to before, can indicate ischemic bowel. So you may see the target sign, absent enhancement, decreased or delayed bowel wall enhancement. Mesenteric haziness, as we saw in some of those other cases, engorged mesenteric vessels, the whirl sign that we just saw, ascites, a large amount. You can have small amounts of ascites in routine small bowel obstruction, but if you have a large amount of ascites, you should think about ischemic bowel. And of course, pneumatosis, mesenteric and or portal venous gas would generally be signs of ischemic bowel in the setting of small bowel obstruction. So one example here, we can see this patient has pneumatosis, air in the bowel wall. And it's a patient that had small bowel obstruction secondary to a ventral hernia with pneumatosis, air in the bowel wall. Now, you could go on and do ultrasound or start with ultrasound in patients with small bowel obstruction, let's say. So ultrasound is better because it's much less expensive than CT. CT is about 4 to 5 times more expensive. It's very easily, quickly done. And it's been shown that it's actually accurate in establishing the diagnosis in the majority of cases that have small bowel obstruction. Some studies have shown that the level of obstruction is actually more accurate than on plain film, which we said was unreliable in some cases, and can identify the cause of obstruction in up to 74% of cases in one study. And it may suggest strangulation as well. So this is a patient that had dilated loops of small bowel, air-filled. They did a sono, and we can see that they're dilated fluid-filled loops of small bowel obstruction was diagnosed on ultrasound. This was another patient that came in with right upper quadrant pain. They thought to have cholecystitis or gallbladder-related disease. However, when they did the right upper quadrant ultrasound, they saw that they had dilated loops of small bowel, and this was concerning for small bowel obstruction. A CT was performed, which showed small bowel obstruction. So problems with ultrasound is that it is somewhat operator dependent, and it can be limited in the evaluation of the bowel and of gas-containing structures. So there is some difficulty with ultrasound. Could we do MR? MR is good because it's insensitive to peristalsis artifact. We don't have to give oral contrast. We can get multiplanar reconstructions. And one study showed that it was actually more sensitive and specific for identifying the presence of small bowel obstruction and the etiology of small bowel obstruction. An example here, We can see that there's again transition between the dilated and non-dilated bowel in a patient with small bowel obstruction. So the ACR has come up with appropriate criteria for small bowel obstruction. This one is for complete or high grade. They give CT an 8, plain films a 7. Then again, there's controversy as to give water soluble or barium, or to give oral contrast at all. Here they say without contrast is an 8, and with contrast, oral contrast, that is, was a 5. And then other things have lower ratings. And then for intermittent or low-grade small bowel obstruction, actually everything here gets a 7. Plain films, of course, are less reliable because we're not going to see those dilated loops necessarily with a low-grade obstruction. So ultrasound they're giving here a 2. This is with a low grade, which is more difficult to diagnose on any study. So back to our quiz. Which patient has small bowel obstruction? This patient is actually the one with small bowel obstruction, has a normal bowel gas pattern, I would say. No dilated airfill loops of small bowel, but turned out to have small bowel obstruction. This patient had ischemia with big dilated airfill loops of bowel. And this patient had right colon cancer, which was causing small bowel obstruction. You can see the dilated cecum here. So the answer was actually A. So in summary, plain films are somewhat unreliable in the diagnosis of small bowel obstruction. Routine small bowel follow-through can be done, however, it may delay the diagnosis for the reasons we talked about. Enteroclysis is accurate, but labor-intensive, invasive, and contraindicated if strangulation is present. And you may not know that the patient has strangulation when you start your study. CT is accurate, easy, and fast. Ultrasound is also easy, fast, cost-effective, operator-dependent. MRI can diagnose small bowel obstruction, but there's limited availability and it's expensive. So thank you for your attention, and if you have any questions, I'll try to answer.
Thank you so much, Dr. Wolf, for that excellent presentation. I'll start by reading out one of the questions that came in through the chat. So this attendee was noting that for diagnosing small bowel, erect plain films of the abdomen still persist in a lot of places as just the routine default primary imaging modality, but are obviously not effective in a lot of cases. So why is that the norm still, given that CT is usually more lucrative?
Right. We still do plain films in most cases that are suspected of having small bowel obstruction. And, as I said, it is controversial why, do it. Why don't you just go to CT? Plain films can at least guide you in the right direction. If there's a high suspicion for small bowel obstruction, they can be prioritized to go right to CT. If there's low suspicion, they might be observed clinically and see what happens. And it can diagnose other things. So it may not be small bowel obstruction. They may suspect small bowel obstruction clinically, but it could be perforation. It could be something else that, not small bowel obstruction. So we still do it in most cases. I would say that some cases will go directly to CT. It depends on the physician who's ordering the study, what they prefer, but we still do a lot of plain films with small bowel obstruction. But again, some people think it's not worthwhile and just go right to CT.
Great. And I think there's another question coming in through the chat. The participant notes that at their institution, they do not use oral contrast in the ED, only IV. And often when obstruction is suggested on these exams, the surgeon wants to repeat with oral contrast, often within less than 24 hours. Is there a benefit in repeating with oral contrast, or would you recommend a small bowel series?
Yeah, we generally don't give oral contrast in the ED as well, unless there's some specific that they want to have it. In rare cases, we'll have to repeat it with oral contrast because it's unclear whether there's obstruction, whether it's ileus, whether it's something else. But in most cases, oral contrast is not necessary, and it can be harmful because it can lead to aspiration. And it's generally, in most cases, not that helpful. It may not even reach the point of obstruction. It delays, getting the scan. We like to get a quick throughput through the ED. So there are occasionally cases that we do have to repeat with oral contrast, but it's unusual.
I see. And then along similar lines, one of the questions I have is if you do get a plain film that shows a gasless abdomen or another sign that is non-specific, as the radiologist, what role do you take in recommending additional imaging in the ways of CT, or do you prefer to correlate clinically, or have the primary team correlate clinically?
Yeah, well, we generally rely on the clinical team because it can be totally normal. We don't know. If it looks normal to us, all I can say is normal. If they clinically suspect small bowel obstruction, they're continuously vomiting, they've had previous surgery, they've had previous episodes of small bowel obstruction, they highly suspect small bowel obstruction, they'll go ahead and do a CT. But we don't have that much involvement in the decision making unless they come to us and say what to do. They have suspected, we'll say go ahead and do a CT. But we leave it to them.
Okay. And then another participant is asking, are there ultrasound diagnostic criteria for small bowel obstruction?
Well, similar to what we do on CT, we're looking for those dilated fluid-filled loops of small bowel. We don't do too much ultrasound specifically for the diagnosis of small bowel obstruction. If we see dilated, loops of bowel, if we're doing a study for some other reason, we'll suggest it, and they'll generally go on to have a CT. So it's really done in cases that are suspected to have something else, not as a primary tool to diagnose small bowel obstruction in where I work.
What would you say are some of the biggest pitfalls or mistakes that are made in diagnosing small bowel obstruction, either on plain films or in CT? Are there any lookalikes that might lead to misdiagnoses?
Yes, certainly. Ileus and the postoperative patient in particular, or ileus in general, the differentiation of small bowel obstruction ileus can be very difficult. As I said, a lot of cases of small bowel obstruction still have air and fecal material in the colon. So if you're going to be using that as your criteria, you're going to be misled. Differentiating of ileus and small bowel obstruction can be very difficult to, especially in the postoperative patient, where some will actually have small bowel obstruction. So that's really the main pitfall. And again, those non-diagnostic cases where there's gasless abdomen, that sort of thing, can be problematic as well.
Okay. Well, with that, I think we were able to answer all the questions. Thank you again, Dr. Wolf, for giving us this excellent presentation. And thank you to everybody who is joining us from around the world. We'll have another scheduled talk with Health for the World next week. So keep an eye out for those emails. And with that, I'll end the session. Thank you again.
Okay, thank you all.